Hi, I'm Dr. Susan O'Brien, and I'm a professor of medicine at the University of California at Irvine. And I'm going to talk to you today about sequencing therapies for chronic lymphocytic leukemia. These are my disclosures. So if we want to talk about chemotherapy-free pathways in the frontline setting, we have three drugs that are available to us. Two BTK inhibitors, namely ibrutinib or acalabrutinib, or venetoclax-based therapy. I'll point out that both ibrutinib and acalabrutinib are approved as either single agents or with obinutuzumab, and venetoclax, of course, is approved in combination with obinutuzumab. So we have those three options. Now, if we go to the relapse setting, there's actually 5 targeted agents we could use. The 3 that we just talked about, and 2 PI3K inhibitors, which are shown in the middle of the screen. Idelalisib, which was approved with rituximab, or single agent duvelisib. So now if you multiply these potential sequences together, you can see that there's many different ways to sequence therapy. But I think we have a little more guidance than just multiplying them together. So we'll talk about that. However, a very important point to make is what we're all interested in at heart is if I'm going to use venetoclax first, how well does ibrutinib work afterwards, and vice versa. And actually, there's very little data. And the reason is these are the pivotal trials that led to the approval of these targeted drugs in the relapse setting. And what you can see is that the vast majority of the patients who were being treated in the relapse setting had received multiple regimens of prior chemoimmunotherapy. Of course, this is very early in the development of each of these drugs. So note that in that highlighted red there, the percentage of the patients who were previously treated with a small molecule was vanishingly small. So there's very little clinical trial data at this point in time. And notice on the right that the summary of this is only 9 of 921 patients from these pivotal trials were previously treated with a small molecule. So this is, as we say, a data-free zone. But how can we analyze this? Well, step 1 is select the best frontline chemotherapy-free approach. There is no available prospective comparative data for starting with a BTK inhibitor versus venetoclax. Luckily, CLL-17 trial developed by the German CLL study group will be the most informative study to answer this question, but right now we don't have that answer. Step 2 is, upon relapse or progression, there are 3 major considerations in selecting the next therapy on the chemo-free pathway for 2 distinct groups. There's either group 1, the patients who started treatment with a BTK, or group 2, those who started with venetoclax. The first important consideration is what was the reason for discontinuation? Was the therapy completed, such as finite therapy of 1 year with Ven-G, and then the patient progressed off therapy? Or did they progress on therapy, which is usually the scenario with the BTK inhibitors, since it's continuous therapy? Or did they come off for intolerance or adverse events? Consideration 2 is what are our options? And consideration 3 is levels of evidence. Ideally, we would like prospective randomized trials. But as I told you, there's very little data in that setting, although we have some. There's prospective registry data. Probably what we have the most of is number 3, which is retrospective real-world data. And if you look at the box on the right, this is very true. Sequences are partially a consequence of the order in which the drugs were approved rather than intrinsic tumor biology. So novel agent naive patients who are relapsed or refractory, in other words, they got chemoimmunotherapy up front. Do we want to use a BTK inhibitor, a PI3K inhibitor, or venetoclax? Remember, they're already previously treated, but with chemoimmunotherapy. I think here we can make a definitive statement that in all circumstances, when clinically acceptable, the data support a BTK inhibitor or Ven before a PI3K inhibitor. And again, there's no definitive comparative data comparing Ven versus a BTKI as a first novel agent in novel agent relapse CLL, but we do have some real world data. So here is data looking at a BTK inhibitor versus a PI3K inhibitor for relapse. So on the left, it's not a clinical trial. It's real-world data in 683 patients, and most of these patients had had prior chemo. Again, in all of the data I'm showing you, that's usually the case. But note if they were treated with ibrutinib as the first small molecule, the median PFS was about 3 years, whereas with idelalisib, it was about 11 months. What you see on the right is actually clinical trial data for the ASCEND trial. That was the phase 3 randomized trial that led to the approval of acalabrutinib as a relapse therapy. And that comparator was acalabrutinib versus idelalisib plus rituximab, or BR chemoimmunotherapy. And you can see that acalabrutinib produced a significantly longer progression-free survival than either repeating chemo, because again, all these patients have had prior chemo, or giving a PI3K inhibitor. So I think we have pretty good data that we, other than a patient where you feel that they're inappropriate for BTK inhibitor, you're always going to pick a BTK inhibitor over a PI3K inhibitor. What about a BTKI versus Ven-R from the Murano trial as first novel agent? Again, both very reasonable, but there's different factors to consider. So if we're going to use a BTKI as the first novel agent in relapse, it's very convenient. There's no infusions. There's no tumor lysis monitoring. That's because none of the BTK inhibitors are approved in the relapse setting with an antibody. There's very long-term efficacy data, particularly for ibrutinib, which was our first available small molecule. And there's much more data, and again, this relates to when the drugs were developed. There's much more prospective data for using a BTK inhibitor up front and then using venetoclax later, although we are starting to get the reverse data too. And several randomized clinical trials with possible overall survival with the BTK inhibitors. What's the benefit of venetoclax? It's time limited. And remember in Ven-R from the Murano, it's 2 years. Antibody stopped after 6 months, the small molecule for 2 years. There's no known cardiac or bleeding risks like there are with the BTK inhibitors. Because you have a time-limited therapy, there's less concern for long-term adherence. And then obviously a potential for cost savings. So different factors to consider. Now, do we have any real-world data comparing in the relapse setting venetoclax to a BTK inhibitor? This is, again, real-world data, so not clinical trial data, looking at ibrutinib as the first novel therapy, in other words, after chemo, or venetoclax plus minus an anti-CD20. And what we can see is that venetoclax and rituximab appears to be producing a longer progression-free survival. But I want to point out a very important point, again, related to the development of the drugs. Look at the number of patients in the legend who got ibrutinib as their first small molecule in relapse versus the number who at this point in time when this was published in 2020 had gotten venetoclax. So really important to note there that although that is a significant difference, the numbers for venetoclax are very small, but suggesting venetoclax might be your first choice in the relapse setting. However, there's no difference in survival. So again, I think leaving it wide open for choosing either a BTK inhibitor or venetoclax. Now, can we choose a BTK inhibitor in the relapse setting? As you probably know, there are 2 randomized trials, both with ibrutinib as the control arm versus either acala or zanu. And let's look at that data. So the Elevate-RR trial was a phase 3 trial in the relapse setting of acala versus ibrutinib. Both drugs were given continuously as we give the BTK inhibitors. Remember that acalabrutinib is BID dosing. Now, a very important point about this trial, and different from the Alpine trial with zanubrutinib that I'll show you, is that in addition to being relapsed, all these patients were high risk. So they all had a deletion 17p or a deletion 11q. And the primary endpoint was non-inferiority on an independent review committee assessed PFS. The patient characteristics show the patients were very comparable. And here we have the primary endpoint. There was non-inferiority on the independent review committee assessed PFS. And in fact, you notice that the curves cross. And the median is about 3 years, which is pretty good for a relapsed refractory high-risk population. That's true with either drug. No difference in overall survival. However, where we see a significant difference is particularly in cardiovascular complications, which are shown at the top. AFib was reduced with acalabrutinib, and hypertension was markedly reduced. As you can see there, the hypertension rate with ibrutinib was almost 3 times as high as with acalabrutinib. In addition, there was less bleeding, although bleeding was minor in both arms, less diarrhea, and less arthralgia with acalabrutinib. So although the efficacy appeared comparable, the toxicity profile appears more attractive for acalabrutinib. Now, the Alpine study, the data that we've seen so far is a little bit different. Number one, this is an interim analysis with very short follow-up. Number two, in this randomized comparison in relapse, there was no selection for high-risk patients. So this is all comers in the relapse setting, and also in this setting, zanubrutinib was given BID. Now, this was an interim analysis at about 1 year, so early on with very limited follow-up. What you see, and the primary endpoint on this trial was the investigator-assessed response rate. What you can see on the right is the investigators assessed a higher response rate with zanubrutinib, 78% versus 62%. However, of notice that PRLs, or PRs with lymphocytosis, were not included in the final response assessment. If you scroll down a little bit, you can see that if we look at the overall response rate, including PRLs, there is still a difference in favor of zanubrutinib at 88%, but the numbers appear somewhat more close, with 81% in the ibrutinib arm. And there also, if you go look at the bottom of that table on the right, you see a benefit in terms of 17p. Now, again, using an investigator assessment, there not only was an approval in response rate, but an approval in progression-free survival. But again, I'll point out that the median follow-up here is about 1 year. So most of the events had not occurred yet, and it is possible the shape of those curves could change. What we also have not seen yet, and we're hoping to see it soon, is the Independent Response Committee's assessment of the PFS. We did see from a press release that the Independent Response Committee has verified the higher response rate using zanubrutinib, but we have not seen their assessment of the PFS. Now, if we look at the toxicity profile, we do see a difference here in atrial fibrillation. And in general, Zanu generally provides the lowest number of AFib events that we see in any of the trials. However, what's very interesting here and very different than what I just showed you for Elevate is there's no difference in hypertension whatsoever. And I would almost argue that hypertension is a bigger problem with these drugs because we know it's not necessarily an early event and it can occur 1 year on therapy, 2 years on therapy, 3 years, 4, 5, etc. So the prevalence becomes very high. Now, I will point out that is this lack of difference in the hypertension rates related to the short follow-up of only about 1 year? And as time goes on, will we see that difference increase? Don't know yet. It's something to keep an eye on. What about venetoclax for CLL for patients progressing on ibrutinib? There actually is clinical trial data here. This trial was designed specifically to treat patients progressing after ibrutinib. I will point out that all of these patients had had prior chemo. The median number of prior regimens was 5, and 45% of these people had a 17p deletion. So a highly refractory group where continuous venetoclax, now single agent, was being tested. Notice in the all patient column in the table that the overall response rate was about 65%, so about 2/3 responded. And notice that the median progression-free survival was 2 years in this highly refractory group. Again, this is the only FDA-approved agent with prospective data in the BTK-resistant disease. And again, multiple lines of prior chemo. So not a pure BTK-resistant after frontline therapy moving to venetoclax, where I would assume the data would look much better. What about the Murano trial, where we know that after 2 years of fixed duration therapy, we saw that the median PFS was 53 months, so between 4 and 5 years, and was obviously much better than bendamustine rituximab. Again, all of these patients had had prior chemo. not prior ibrutinib. And in this trial, there actually is an overall survival benefit, although crossover was not allowed on this trial. So patients failing BR could not get access to Ven-R. So what if we use frontline Ven-G? Now it becomes even more complicated. Why? Because with finite therapy, we also have the option of retreating. So we could retreat with Ven-G if we can get approval for using obinutuzumab again, or Ven-R, which is the approved regimen from Murano, or even if we wanted to, continuous single agent venetoclax, which is also approved and was the original approval. If they get a covalent BTK inhibitor, then you could also, if they got Ven-G and you don't want to use Ven again for whatever reason, maybe their remission was short, you obviously can use ibrutinib and acala. And let me just point out the reason you don't see zanubrutinib here is that although that drug is approved, it is not yet FDA approved for CLL, but based on both a frontline and a relapse trial, that drug will be approved for CLL by next year for sure. And so then we would have three options. Or we have the PI3K option, but generally we're not going to use a PI3K preferentially compared to a BTK inhibitor. So this is looking at data following venetoclax discontinuation. So all of these patients have generally had chemo and then venetoclax, but what you can see is that there were 44 BTKI naive patients, so had only had as their prior small molecule Ven. And you see a really good response rate of 84% and a median progression-free survival of 32 months. So we don't have trial data like what I just showed you for patients failing ibrutinib and going on to Ven, but we have some good real-world data here of patients failing Ven going to BTKI, again showing very nice outcomes. So continuous emerging data that it appears we can make our choice and go from one small molecule to the other. What about, however, assessing a PFS with in prior BTK resistant patients? Well, note that if they were intolerant, which is the top curve, so they had previously got a BTK, then got Ven, and now they're getting a BTK inhibitor again, they actually do very well if they're not resistant. However, note if they're resistant, the median PFS was very short. Now you might say, well, why the heck would you be treating with a BTK inhibitor in a patient that's already resistant? The reason that was done is there's actually some data that the CYS41 mutation, which we know is very common in patients becoming resistant to ibrutinib or acalabrutinib, actually disappeared in patients receiving venetoclax. So the hope was that maybe if that were the case, that clone disappeared, you could go back and use the BTK inhibitor. But clearly this real world data suggests that that's not going to work. We also have a little bit of data for using BTK after Ven from the trial from the Australians who, remember, did most of the Ven trials were done originally in Australia and Asia. And we see that the BTK inhibitors were quite effective in these venetoclax resistant patients. And these were truly resistant because they were on previously, but were on continuous venetoclax. So progression generally was on therapy. And they do quite well with the BTK inhibitor. However, the emerging real-world data suggests that if patients have failed two small molecules, namely here venetoclax and a BTK inhibitor, the PI3K inhibitors at that point don't seem to really result in durable remissions, which is a shame because that's exactly the patient population, right, where we would like to use those drugs. But again, keep in mind, most of these patients had also had prior chemo. It's not a pure small molecule population in terms of patients only failing Ven and a BTKI. Maybe the PI3K data would look better, maybe it won't. Well, what are we going to have for some of these patients that become double refractory? We're very excited about the non-covalent inhibitors. This is pirtobrutinib. Note the kinome profile on the left, how selective this drug, which when I show you the toxicity data is probably why the toxicity is so minimal. All that you're seeing on the right are xenograft models showing that this non-covalent inhibitor is also very active, not only against wild-type xenograft, but those with the CYS41 mutation. What's so attractive about being non-covalent? Nothing. The reason these drugs are attractive is because they bind in a completely different binding site than all of our current BTK inhibitors. And by doing that, are effective in patients with a mutation and happen to be reversible. So this was a very large study with a dose escalation and expansion. There were multiple diseases, as you see here, but we're going to focus on the CLL population. These data are 261 patients. You see that 100% of these people had prior BTK therapy, although if you look at the bottom, 25% came off for toxicity. So not truly resistant, but about 75% came off the BTK inhibitor because they had progressive disease, and about 43% had a mutation. And you see an enrichment here, as you might expect, for 17p deletion and p53 mutation. So here's the waterfall plot. We see really nice response rates. You can see here the overall response rate is 68% in these patients. And again, this is mostly patients who not only failed a BTK inhibitor, but extensive prior chemotherapy. So excellent response rates. What about durability? On the left, you see the PFS in those who've had a median of 3 prior lines. So they've all had a BTK inhibitor or probably didn't have venetoclax. And that median PFS is still not reached. In the right, you see patients failing BTK, failing a BCL2, with a median of 5 prior lines of therapy, again, because they all had started with chemoimmunotherapy, and still you see in this highly refractory group an excellent median PFS of 18 months. So not only good response rates, but durable. The responses don't seem to matter in terms of durability, whether the patient is mutated or not. And here's the toxicity profile. So note that no DLTs were reported and an MTD was not reached. Look at the all-grade toxicity, which is shown in that table, the last right-hand column. You see very low toxicity rates, and you see almost no atrial fibrillation or flutter. I think what's really impressive is that on this trial, in a very refractory group, 1% of patients discontinued due to treatment-related adverse events, which is, maybe you could argue they're very refractory, so they're more dedicated to staying on study, but that's still one of the lowest discontinuation rates I've ever seen for AEs. So very exciting data in terms of efficacy as well as toxicity. So I'll just finish off here with some thoughts about chemo-free management of CLL. Let's start on the left. If they got frontline venetoclax and obinutuzumab and progress on therapy, of course, we're not going to use ven again. We're going to go to a BTK inhibitor. But if they progress after therapy completion, especially if they get a few years, one could consider going back to venetoclax, or one could use a BTK inhibitor. If they came off ven for intolerance, you could consider retreatment, say with a lower dose or better supportive care, or you could switch to a BTKI. If we move to the right now, what if they got a frontline BTKI plus or minus anti-CD20? If they progressed, right now, all we have is venetoclax-based therapy, although with the approval of pirtobrutinib, that would be another option. If they come off for intolerance, then of course you can switch to an alternate BTKI or use Ven-R per the Murano trial, or vice versa. Of course, I would have to put my plug in that we always want to consider a clinical trial, because that's the only way we can ever move the field forward. Of course, cellular therapy for the most part would be clinical trial. So I'll stop there, and thank you for your attention.